First, I would like to invite Dr. Mangala DISSANAYAKE. He is going to talk about pathophysiology and classification of ischemic optic neuropathy.
Thank you. Good evening, everyone. Thank you, Dr. Sri, for your kind introduction. I'm going to start with the pathophysiology and the classification of the ischemic optic neuropathy. Basically, ischemic optic neuropathy is the process which occurs in the optic nerve due to the ischemia. So what will happen with the ischemia? The ischemia is going to affect the mitochondria, depleting the energy which needs for the cell. So it makes the neuron to secrete excessive amount of glutamate, which ultimately lead into influx of calcium ions into the neuron. So these calcium ions will act via calcium receptors, especially NMDA, and it will trigger a cascade of events, including enzyme activation, cellular component breakdown, and free radical release. So the ultimate product will be apoptosis and the necrosis of the neuron. So it will lead to a morphological change of the nerve and the inflammation, which might further compromise the blood supply and building up a vicious cycle. So there's something called ischemic penumbra, that's the area surrounding the co-infarct. So the important is neurons in this area initially viable but vulnerable to a delayed death if the blood supply is not immediately restored. The loss of blood supply may occur due to numerous reasons and affects various areas in the optic nerve. So according to the cause and the place of involvement, the classification of the ischemic optic neuropathy has been built up, basically. So we just have a quick look at the blood supply to the optic nerve. It has invariably a complex blood supply. That's why we do get variable outcomes later. So optic nerve head, we call it papilla or optic disc, has a superficial fiber layer and three other parts, we all know that, prelaminar, laminar, and retrolaminar, classified according to the position of the lamina fibrosa. Optic nerve has three parts: intraorbital, intracanalicular, and intracranial. So if you consider the optic nerve head, the superficial nerve fiber layers are supplied by the capillaries from the central retinal arteriole, which anastomoses with the prelaminar region. Sometimes we do get a retinal arteriole supply as well if it's going to be there. Prelaminar part is main supply is the short posterior ciliary vessels and the peripapillary choroidal vessels. Actually, peripapillary choroidal vessels are the product of short posterior ciliary artery as well. In the laminar region, short posterior ciliary artery plus arterial circle of the sin inhaler. Again, the major contribution is there from short posterior artery for the arterial circle of sin inhaler. The retrolaminar part is via the recurrent pile vessels of short posterior ciliary and centripetal and centrifugal branches from the pile plexus, which is a product of ophthalmic artery. So this is a schematic diagram of the blood supply. And at the optic nerve head, if you consider the optic nerve, the intraorbital part, arbitrarily we can divide into two parts. This is periaxial system and the axial system. Periaxial system is mainly from ophthalmic artery and the branches, including long posterior ciliary, short posterior ciliary, central retinal artery before entering into the nerve, and the lacrimal artery. The axial system is basically from the central retinal artery. Once it has entered into the nerve, it gives intraneural and central choroidal branches. The intracanalicular part is periaxial system plus the pile plexus, which is a product of ophthalmic artery. Intracranial part is about the same. So just diagram again, you know, the AIO in this anterior ischemic optic neuropathy is going to affect more anteriorly, and we have another entity called posterior ischemic optic neuropathy is going to affect the posterior part of the nerve. Just something to elaborate, we do get visual field defects with the ischemic optic neuropathy. So some studies have, there have been studies, they have shown all three parts. That means superior field, inferior field, and central field can be affected in variable degrees. So there are identified types of visual field defects with the ischemic optic neuropathy, basically arc weight and altitudinal defects, superior and inferior. And you do get central scotomas and paracentral scotomas. Rare occasions, you may get nasal defects as well. So bilateral involvement can cause binasal hemianopia, rare occasions. Just to elaborate the visual field to refresh the classification of ischemic optic neuropathy. So everybody knows that it's a very basic things. So two things: anterior ischemic optic neuropathy, the main entity, and the posterior ischemic optic neuropathy. So anterior ischemic optic neuropathy, we do classify into two entities: non-arteritic and arteritic. Non-arteritic, still the pathophysiology is very controversial and unclear. Basically, medical reasons do affect this problem. So it's kind of a circulatory insufficiency or infarct within the retrolaminar portion of the optic nerve head that is supplied by the short posterior ciliary arteries. That's the territory of short posterior ciliary artery. So it's a kind of assumption actually. There's no still proven mechanism. But arteritic anterior ischemic optic neuropathy is basically equal to giant cell arteritis. That is the main cause. Usually do get 50 and plus. Predominantly you get profound loss of vision with a lot of changes in the optic nerve. And there's a genetic predisposition. Caucasians are getting affected more than the other entities, but there are a lot of other differences in the ethnicity. Posterior ischemic optic neuropathy, the rare entity than the anterior ischemic optic neuropathy, but you do get, there are three types: non-arteritic, arteritic, and perioperative. Non-arteritic is again as rare, but still it can happen due to multifactorial systemic diseases like diabetes and hypertension. But researchers have shown that glaucoma, carotid artery diseases, dissection-like things, migraine and hemodialysis and head injury can cause this type of posterior ischemic optic neuropathy. Arteritic is lesser, still less, but the GCA being the common cause involving the posterior ciliary artery. Perioperative is going to affect the younger patients, which can cause commonly bilateral profound vision loss in about 70% cases. Predisposing factors, male sex, obesity, sleep apnea, medications like amiodarone. So those are the basic classification and the pathophysiology. So I'll hand it over to my colleague for the rest of the session. Thank you very much.
Thank you, Mangala. You have painted a picture on basic aspects of